Hi, everyone. Welcome back from the break. Hope you had a good break. Today, at this time, we're going to begin session number 3, entitled Making Healthy Transitions from Pediatric to Adult Services. And I'm proud to introduce our speakers for this morning. Dr. Amy Houtro is a professor of physical medicine and rehabilitation and pediatrics and the endowed chair for pediatric rehabilitation medicine in the Department of PMR at the University of Pittsburgh School of Medicine, where she's also the vice chair for quality and of pediatric rehabilitation medicine. Dr. Kripke is a family medicine physician specializing in the medical care of adults with developmental disabilities. She is a clinical professor in the Department of Family and Community Medicine at UC San Francisco. She's also the director of developmental primary care. So together they will be talking about transitions from pediatric to adult services. I'll hand it off to you.
Well, thank you. It is a real pleasure to be here. My name is Amy Houtro. I am sitting in a room that has animal pictures in the background, a black couch, and I'm wearing a bright pink blazer, as well as a multicolored shirt and teal glasses. I have shoulder length brown hair and my skin is pale, but my lips are pink. And I'll let Clarissa introduce herself.
I'm Clarissa Kripke, and I am sitting in my office with what I hoped would be a blank background, but really you can see the mess in the back, and I'm wearing a red sweater because red is a power color, and when I want to feel powerful, that's what I wear. And I have salt and pepper brown hair and glasses and pale skin.
Well, I just want to give everyone a little bit of orientation to this session because I have a long relationship with Dr. Kripke. My very first job out of residency was being the sole pediatric rehabilitation medicine physician at UCSF, where Clarissa currently practices. And so when I arrived there, I very quickly discovered that many of my patients, although I am a pediatrician, were in fact older than I was. And I made it my job to transition the ones who were older than I was to adult care. There is, unfortunately, in the United States, a major deficit in adult healthcare providers who are excited, capable, and willing to take care of individuals who have childhood onset disabilities. And I cannot tell you how grateful I was to find Clarissa was right in my same yard. Right? We were sharing and able to have something happen where I could successfully transition young adults who had disabilities to her practice. And if they weren't right for her practice, she was always available to help me find people who would serve as providers for children that I was graduating from my clinic. And when I say children, I mean adults. Some of them in their 30s and lots of them in their 20s. So by orientation, we have a long-standing passion about transition because it affects both of our practices. And then also, I have lived experience. I am a person with childhood onset disabilities. I was born with a very rare skeletal dysplasia, the kind of condition for which when you're a small child, they take pictures of you that they might use in textbooks. And I always worried when I was in medical school and residency that I would see my own picture in a textbook. It did not happen. But I remember my own transition, how unsuccessful it was because there were not adult providers who understood my condition. And I often went back to pediatric subspecialists to seek their guidance well into my adulthood. I was already getting gray hairs by then and still needed to do so. And so my own lived experience also fuels my passion to make sure that we're doing the best we can to help children with disabilities through the various transitions that they have in life. One major one is around the time of adulthood when you transition from pediatric healthcare to adult healthcare. And I would like to pass over to Clarissa to give you a little bit of her perspective.
So I also have lived experience as a parent. I have a 20-year-old autistic child who needs care with all basic activities of daily living, and who communicates by pointing on a letterboard with the help of an aide who happens to be me, and has other aides, but I'm the most proficient. So we're in the middle of this transition thing, and Amy is describing something that sounds very smooth, but the problem is not so much with transition, it's that there's nothing to transition to. And as much as I would like to take care of every person with a disability in Northern California, which is often what I'm asked to do, I can't. And when people ask me whether I am going to, who else if not you, I don't have a good answer to that, frankly. And if I keep sending people to the same people, to the same handful of people, then basically put them out of practice, because they end up having to try to take care of people with complex disabilities back to back in a clinic session where they're given no extra funding and no extra support, and nobody can do that. I couldn't do it, and ended up having to change my practice from a general practice where I serve people with disabilities to a more specialized ones with special funding. I was able to get the special funding, but it's not, and that special funding model has been scaled, but it's not available to everyone who needs it. So there, yeah, go ahead.
I was just going to say, what this makes me realize is we really need to help healthcare practitioners at every stage of their learning, whether they're attendings or whether they're in training, medical students, residents, be prepared for the real likelihood that an important subset of your practice will be people with disabilities. And both of us, Clarissa and I, both have practices that are now wholly dedicated to the care of individuals with disabilities, but that's not typical. And we know from what we've heard earlier in this conference that there are a lot of barriers, and we understand that there's entrenched ableism, that there are limited expertise, and all the barriers that exist around being able to safely take care of patients with disabilities, the equipment that you need, the expertise that you need, and how you're able to do that and still make the next appointment and do all of the things you're expected to do from a regulatory as well as insurance perspective to keep your practice afloat. And that there have been longstanding issues, especially when we consider the intersectional issues of disability with classism and racism, colonialism, that make it even harder for people with disabilities to access timely, high quality care that is culturally responsive and respectful. And we picked the topic of transition because it's something we're both very passionate about, but woven through our conversation about transition are embedded in these issues of who's available to do it. How do we address workforce shortages? What are the kind of things that we need to consider when we consider training? And how do we dismantle the isms, ableism, racism, classism that drive how so much of healthcare is structured? But just on the fundamental level, I think we need to understand what transition is versus a transfer of care, which is like when the actual time frame where I, as a pediatric rehab provider, might hand off to an adult provider. So Clarissa, do you want to talk a little bit about that? What transition is kind of in a 30,000 foot view, and then it's a little bit more honed in into the healthcare view?
Yes, so I'm a family physician, and unlike pediatricians, we don't abandon our patients at a certain age. We take care of people across the lifespan, but there are many transitions in healthcare, and I think of transition as having three components: the people involved, the activities involved, and the place involved. And there's actually research that shows that when you break up people's core relationships, their family relationships, their key caregivers, the activities, like even a promotion at work is stressful, even if it's a good thing. If the activities change, it's stressful. And the location, if you change housing, if you change location that you're doing things, it's stressful. And if you have all three of those things happen at the same time, it leads to illness. It actually makes people sick, and it's very destabilizing. So anytime I think of transitions as not just being from childhood to adulthood, that's a very important transition and important for adolescents who are going through that, and they do need to change their relationship with their doctor and take on the responsibility of medical decision making for themselves, or with or without support. But that's not the only transition. There's transitions when parents die. So a lot of the transitions happen around or develop disabilities of their own, which often happens when people are around age 30, then their parents are unable to provide the same level of support that they did when they were young. So often this doesn't happen at 18. This happens as parents' ability to be involved shifts. And there are other kinds of transitions where people change their housing structure, like move out of their family home into whatever they're into an adult home, a group home, their own home, or somewhere else. There are transitions that happen when people change the level of care, for example, coming out of the hospital or going into a hospital. So anytime you're changing the people who are providing your core support, the activities, and the place is a transition. And so I think of it in those broad terms, and those happen throughout people's lifetimes, sometimes in planful ways and sometimes in unexpected ways. And it's always better when we do it planfully and when we try to stagger the person, the activity, and the place instead of changing all of those up at the same time.
Well, you bring up something that's really important, the planning part. And that when we can do things and anticipate a change is going to happen, we can make that much smoother. And yet we know that healthcare transitions tend not to be smooth. And in fact, it's the age after a transition away from pediatric healthcare that increases your risk of poor health outcomes, limited access to healthcare services that really can be detrimental for all youth, but in particular youth with disabilities who have an increased mortality during that age range. And to me, it speaks very, it breaks my heart, right? As a pediatrician, I often get to see children grow from their infancy to their teen years. And to think that we're sending them into a space that's less healthy for them is really, it's heartbreaking. And I know I can't, just like you can't have practice where you serve everyone. Children have to age out of my practice because there are other children that need to enter it. And there's too few people in healthcare that really are passionate about taking care and partnering with people with disabilities and their families to optimize health, function, and well-being. And that partnering, I think, is really an important concept. And you had mentioned, Clarissa, this issue around supported decision-making and other types of supports that people might have. I'm wondering if this would be a good time for us just to chat a little bit about how we think about goals of preparing for transition and how that might relate for someone who may need support with decision-making and support with various other aspects of their lives.
So we often talk about adulthood, that a goal of healthcare might be independence. And a lot of adults are going to, we can reasonably expect, are going to continue to need lifelong supports for personal assistance, for decision-making, for communication. And so being an adult needing support doesn't mean you're a perpetual child. It means learning how to set boundaries and how to hire and fire, who to trust, how to communicate if you're being mistreated, and how to communicate your own goals. And so often I will get parents coming to me saying, do you know any good programs? My kid is aging out and I'm going to have to find something else for them to do. They're not going to get their school supports anymore. Do you know any good programs for a person with autism or a person with cerebral palsy? And I said, good programs for, I know nothing about this person you're talking about. I don't know what they're good at. I don't know what their strengths are. I don't know what they're interested in. I can't answer that question. And so people don't, you can't arrive at the age of 18 with your parent having made every single decision in your entire life and never having learned how support systems work and never having talked to your own doctor and take on that responsibility all at once and expect it to go well. So I'm wondering, in terms of setting goals and having the skills to set your goals and having the skills to know what kind of support is helpful to you, what can you do in a pediatric oriented practice to prepare people, because pediatrics is very supportive and proactive, and adult care tends to be very reactive, even though people with disabilities continue to need proactive supports. We need to reach out and find out whether people are doing well and if their goals are being met, and not just sit here and wait for people to ask for our help. So what can we do earlier on?
Well, I think you said something that was just so important, the ability to communicate and express your desires and your hopes and your goals and your interests. So one thing that often happens is that parents assume the responsibility to speak on behalf of their child. That happens with children who don't have disabilities, but more so with children who do. And I think promoting that autonomy at every stage is really important. Like you mentioned, Clarissa, before, we have transitions in many places in our lives. You know, we talk about in pediatrics, a school transition, getting ready to be in a classroom, for example. But one thing I feel that we could be doing much better in the field of pediatric disability medicine and pediatric healthcare in general is promoting communication strategies for those for whom verbal communication, verbal expressive speech isn't the most viable or effective mode for them. And I think, you know, one challenge we face oftentimes is that there is a misconception that if you give someone a strategy that is not verbal communication, that you will hinder their development of verbal communication. And that is frankly not true. For a child who's deaf, hard of hearing to learn sign, that does not limit them from having some amount of verbal expression. For a child who is nonverbal and has autism, giving them a communication strategy benefits them and benefits those around him who learn how to understand that person better because they have the ability to communicate. So that's one piece. But I want to bring in something that I think I want to challenge all of us who take care of children with disabilities, is to recognize that child with disabilities as a person unto themselves, with their own interests and the things that excite them and the things that they don't like, and really use the opportunity in relationship building to talk to that child and work to understand them. And then at very early ages, children can learn things like, what are the medications that you take? I am constantly giving homework in my clinic. So I give kids homework all the time. I note it in the chart. And then when they come back and follow up, I ask them how they did on their homework. It could be learning what their medications are, or coming up with something that they want to do as a special project. Or it could be really simple. And just something, just tell me a story. Because I want to help those children develop their autonomy and skills. But one piece that I really wanted to hit home after listening both to Peter and to Alice earlier was this issue around, and you have mentioned it, Clarissa, that somebody is this goal for independence isn't always the goal. Might not be first achievable, and second, it might not even be what somebody wants, right? Interdependence, culturally, many cultures really value interdependence. And I think as a disability culture, we often understand that in ways that other people in the US might not. And so I was hoping you could talk about how you frame with families conceptually what goals are around long-term supports and how you envision that when it might go against what a family member had originally hoped for their child.
Well, that's a really important point. What is the goal of care? And in the Office of Developmental Primary Care, in my work, is really around how do we apply neurodiversity principles and how do we apply the social model of medicine to the practice of medicine. And it's critical to clear clinical thinking, because when we want to I sometimes talk about the need for healthcare to go beyond how do I label them, how do I drug them, how do I label them, how do I drug them. That's often what people are interested in and what they think about, or how do I cure them, or how do I make them more normal. But the goal of healthcare is full participation, is to maximize your potential. And in order for people to maximize their potential, they need to have a dream and they need to have their own goal. And we need to think more broadly about not just how we can impact the person through medications or interventions or surgeries, but also how can we improve the social and physical environment in which they live so that they can fully participate. And so a lot of times with developmental disabilities, people have conditions that are not amenable to pills and surgeries, and people are living with their disabilities, living good lives with their disabilities, and the interventions that we're doing are improving their social and physical environment. And doctors have an unbelievable amount of control over the lives of people with disabilities. You can't take the bus without a doctor's signature. You can't get access to any disability services without a doctor's signature. Sometimes you can't visit your grandmother, or even have somebody help you wipe your bottom without a doctor's signature. You need a doctor's signature for everything. And that requires a lot of humility on the part of us as physicians. And with some of the disability justice things that Alice was talking about, and how we designed our system to require that much physician intervention, is something that I think we need to think more about. With Dr. Hinshaw's talk, we know where that came from, but I don't think that's where we should be going. And I see some backtracking politically, where people see the healthcare system as being better funded than the disability system, and trying to insist that health insurance take on more responsibility for funding disability services, and that's seen as giving more access. But it's really putting us backwards 40 years in terms of our disability rights, in my opinion, because it's putting doctors back in control and making the goal, instead of full participation with families and people with disabilities as full partners in setting those goals and choosing those programs, back into a system that's based on medical necessity, and back into a system where people don't care whether you got to the holiday party with your family. As long as it doesn't wind you up in the hospital, we don't care about it. As long as it doesn't cost the healthcare system money, we don't care about it. And where doctors make decisions about what kinds of interventions you get. And I think we need to be very careful about going backwards in that direction.
Yeah, I mean, I think the over medicalization of disability services is a real issue. And it certainly comes up in transition, where there's this heavy medicalization. And unfortunately is in a medical system that is not particularly well equipped to serve. I can tell you, as a recipient of paperwork to get individuals with disabilities the things that they need, I wish that the system wasn't designed the way it's designed, because that medicalization serves often as a barrier. And I'm particularly lucky in my practice that I have case managers and social workers and access to behavioral health specialists and other subspecialists to help me optimize the health function and well-being of the children under my care. But I know that's not the case most of the time. And so if we're thinking about like on the ground right now, do you have thoughts or advice about what providers should be doing when they have limited resources? And then thinking, in a more idealized way, what are the right team members? Who are they and what are their roles?
When I think about healthcare for people with disabilities, it's interdisciplinary, team-based care with patients and their supporters at the center of the team. And in terms of team members, I think of it in 3 separate categories. At its most basic, it is your direct support team, the people who provide you support on a daily basis. And that team can be very simple. It can be you and your mother, you and your spouse, or it could be very complex. Many of my patients have 50 people with multiple shifts of direct care support people and consultants, lots of people involved in their direct care. So, but you need people with developmental disabilities who have functional limitations in 3 or more areas of major life function are getting help, or they're not going to survive, frankly. So we know they have a team, and you need to find out who that team is. The first part of it is their direct support team, who's providing their day-to-day care. The second part is the disability service systems that they're engaged with. That could be schools or higher education, disability services, vocational rehab, Medicaid, Medi-Cal, Social Security, all of those systems, regional centers or whatever disability service system, all of those systems have caseworkers, they have legal responsibilities, they have people who oversee them or agencies that oversee them, and you need to understand what they're connected with and what they're not connected with that they might be eligible for and might benefit from. So there's the disability service systems, there's your direct support systems, and then there's the medical systems like specialty care, durable medical equipment, dentistry, pharmacy, the medical systems. And we as physicians often take the history to find out who that medical system of support is, but we really don't get a good history on how the direct support systems are funded and organized and who's involved in that, or what other systems people are involved in. And if people need supports and they don't have them, our services fail. I can be the greatest doctor in the world and get you the right medicine, but if you don't have the support to take it properly or to notice and report when there are side effects, or if you don't have the support you need to be a patient in the system, then my effectiveness as a physician is greatly diminished. And therefore, if somebody doesn't have a strong enough support system in place, that's the place to start, even before I try making any diagnoses or making any medical recommendations.
That's so helpful. It reminds me that although we don't want all these transitions to happen at the same time, often they do by force of the legal statutes, right? So age of majority, when you turn 18, for example, a lot of things happen. And you just mentioned SSI, for example, redetermination of your disability benefits happens at this time. But another one, and I think one that's really important that is would be helpful for us maybe to talk a little bit about our supported decision-making and the legal ways that people can have advanced directives or power of attorney, and focusing really on this self-determination, we've used that term, autonomy and self-direction, with the ultimate goal that we're all self-actualized, being all that we desire to be. But knowing that some individuals are going to need support throughout their life, as you said, there are these different legal models set up so that people, a parent, for example, or a spouse, can either help with decision making or make decisions on behalf. But I think that's like very confusing to a lot of practitioners. As someone who deals with this like day in and day out, what advice or guidance do you have for individuals as they're helping their patients and families through this?
So the disability community has introduced the idea of supported decision-making, which is a more naturalistic way of making decisions. We all rely on people more knowledgeable than us for support to make decisions. Many of us defer to our doctor's advice. Many of us defer to our lawyer's advice or our accountant. We all, or family members even, or trusted friends. We all seek out the opinions and the support of others to make decisions. For people with disabilities, too often we say you have an intellectual disability, or you have a communication disability, you have a disability, and therefore my job as a doctor is to find out who makes decisions for you, as opposed to how can I support you and accommodate you to make decisions for yourself. And so even a power of attorney is transferring decision-making to a third party. There's a lot of people, well-intentioned people, who are active in helping support transitions, who think the way to be supportive is to get people who are going to need support conserved, or guardianship is the term that's used elsewhere in the country. In California, it's called conservatorship, where you basically hand to a third party, often a parent, sometimes a public guardian, a complete stranger, the power to make all the rest of decisions for the rest of your life, a single person to make decisions, all your decisions for the rest of your life. And that is a huge power when people are given that kind of power, as the Britney Spears conservatorship has shown us. Absolute power leads to abuse, even if it's well-intentioned, and it's a huge responsibility to do that for another person is a huge responsibility. And people think that often people are doing this because they want to keep someone safe, because they have been providing support and want to continue to do that. But we don't need this legal procedure, which actually doesn't empower families, it doesn't empower people, and it doesn't empower parents. The person it empowers is a judge, a stranger, somebody you don't control, who can make any decision they want about who that conservator is and what they're allowed to do. And that will follow you around for, indefinitely. And the alternative to that is supported decision making, where you can choose trusted supporters to support you to make decisions, and you can choose more than one person to serve in that role. You can choose more than one person to make different types of decisions, like the person who helps you decide whether you're going to use birth control or not doesn't have to be the same person that does your taxes and advises you on how to spend your money, or is your representative payee for SSI. They don't have to be the same person. If that person is unresponsive, or you don't like how they're providing support, or they don't listen to the kind of support you need, all you have to do is switch them out and say, I don't want that person, I want a different person. And so supported decision making is something that the healthcare system doesn't know a lot about yet. The disability community is starting to understand it and starting to implement it, but it won't be successful unless healthcare professionals recognize it, welcome supporters into the conversations, provide them with information, and respect decisions that are made with support.
Well, this is so incredibly important because in my own practice, I have a lot of families who get advice somewhere along the way that they need to become a guardian. So that's in Pennsylvania, we call it guardianship, but it is what you've explained. And, you know, the Free Britney movement really helped people understand how incredibly controlling it is. And often with the best intentions, these parents want to make sure that their children are well supported and cared for, and acknowledge that their child may not be able to be independent with decision making. But it seems like that's a pretty big hammer for the size of the nail, because what we really want is just what you talked about, supported decisions, and that's a very typical thing. You explained how we might turn to different people for different things, regardless of our disability status, right? And that gets back to this idea that we are in fact interdependent, and we should celebrate that, not try to destroy our interdependence. But as a pediatric rehab provider, I think one of the challenges we face is this kind of, from the outside, people are saying guardianship, guardianship, guardianship. And it seems so much more simple and straightforward. So what I've been doing in my practice is really engaging our medical legal partnership on this topic. And lots of health centers have medical legal partnerships. And I'm very explicit, and the team that I work with fully understands and embraces the concept, or the intention that we are finding the least restrictive option, and that we're going to do things prior to the time that that decision has to be made at the age of majority that will help us and help the individual be a part of decision making. I often request neuropsychological testing to find people's strengths, and then also to identify where there's opportunities for us to make recommendations or provide services to, for example, help with communication and problem solving that really will help shape an ongoing plan over time that gets somebody ready for adulthood with supported decision making. But the light switch kind of problem at the age of 18, I think, really catches people off guard. And I would say there's probably way more individuals who are in guardianships or conservatorships, not because there was any malintent, but because the other options didn't seem feasible or reasonable, or were even offered at the time. And you know, when I think about my medical school training, kind of the legal aspects, I never got that in medical school, and I really wish that I had. I think I would be a better provider today over the course of my career if I had been given that or knowledge, or even knew that I needed to have that knowledge, which I didn't even know what I didn't know back then. One of the things, as I mentioned before, is I'm very lucky to have this interdisciplinary team, which is also not a model that's embraced very much on the adult side. Do you have thoughts or ideas about, given the current state, how best to partner when you're taking care of adults with disabilities with social work or community agencies to really achieve this ideal of as much autonomy and self-direction, but interdependence and supported decision-making?
I do think that there are some movements to better support home care, and I think home care models enable more of the team to get together at once and allow you to be away from the distractions of a clinic, and recognize the importance of families and caregivers and roommates and the other people who that circle of support that provide informal care. They're a critical part of the healthcare team, and to allow you to incorporate them. There are people who have disabilities who can be cared for quite well with reasonable accommodations in a clinic-based model. In fact, the majority of people with disabilities, I think that's true. But when you ask people with disabilities what what are the barriers to you getting care? And they start listing off, well, the physical plant isn't accessible to me. Your phone system isn't accessible to me. The people in your office don't have the training they need. They start listing off every element of your clinic. And if you start to change every element of your clinic, how long your appointments are, how you're scheduled, everything about it, in what sense is that reasonable as an accommodation? And in what sense is that still a clinic if you really fixed all those problems? So I do think that people who have more complex needs benefit from special practices with special funding. For my patients with complex developmental disabilities, it's an order of magnitude more work. So 100 patients is a full-time job, not 2,000 patients for a typical primary care doctor. And you can't absorb 100 patients with complex disabilities into a practice that's trying to serve 2,000 patients. And you're really going to need special funding and that team-based care with nurses and phlebotomists and pharmacists and other people who have some disability orientation. So I think we need both models.
Yeah, I think that's right. Something you often say is how important knowledge is, and knowledge as power. And it seems like a lot of what we're talking about today is where that knowledge needs to lie and how we advance that knowledge to the other sectors and then share our knowledge. I see that Peter has joined us on the screen, which means he's probably got some questions for us. Is that right?
I'm back.
You're back.
Such a great discussion. There's a question from the audience that directly ties into what you guys were just talking about. And how can we motivate more adult PM&Rs to want to work with disabled adults, especially those with complex disabilities? Is there a name for that niche subspecialty? Are there adult clinics analogous to PEDS, full day CP clinics, et cetera, in the country?
So what a great question. It is part of my mission to help address this exact thing, having more PM&R doctors who are interested, desire, and trained to take care of adults who have childhood onset disabilities. It is not the model in most PM&R residencies, so that's physical medicine and rehabilitation for audience members who are not familiar. It's a discipline in medicine that is really focused on function and recovery after injury, illness, or other kind of major life event that results in disabilities. And there is a pathway. A number of individuals who are trained in pediatric rehabilitation are lifespan practitioners. There are also a subset of adult providers who either had some amount of PEDS rehab training or didn't, but are very interested, who do have their practices. But there are about, I would say, 10 clinics around the country that are multidisciplinary spina bifida clinics for adults with spina bifida who still have urological issues and still have all these other multidisciplinary needs. So it makes sense that the adult clinics support those needs as well. But I'm actually not sure about the specifics around adult multidisciplinary cerebral palsy clinic, which of course they would benefit from interdisciplinary care as well. But I think we have to recognize that regardless of your training pathway, whether it's in physical medicine or rehabilitation or any other discipline, that knowing how and developing skills in being a healthcare provider for people with disabilities is essential. 1 in 4 adults has a disability. Clarissa and I take care of individuals with disabilities that are quite impactful in terms of their functional implications. But every doctor sees people with disabilities in their practice. So it's as a discipline, every healthcare provider, all those other disciplines, we need to do better in terms of preparing individuals with cultural humility and competence to take care of individuals with disabilities in their practices. I'll get off the high horse now.
Sorry, Dr. Kripke, do you want to add to that?
Well, I think that having regional expertise is really important. So you talked about some 10 special centers around the country. Maybe, I don't know how many we need, but it's one thing to travel for specialty care where you get a very elaborate evaluation for a complex seizure disorder, for a complex physical disability. There are models where we can take those centers of excellence and expand that through telehealth or through mobile clinics where people with that expertise go out into other communities. But in California and in much of the country, people live in rural areas or suburban areas or areas where there aren't enough people with similar needs like there are in concentrated urban areas like San Francisco, who still need those services. And so we should think about some things need to be local. Primary care needs to be local. If it's not, you're just going to end up using the emergency room. Dental care, the therapies like behavioral therapy, speech therapy, OT, PT, those need to be local, and mental health care needs to be local. And those specialties tend to be the ones that are the most specialized when it comes to adults and most different from how people were trained in residency and need special funding if they're going to be effective, and special training. And then for people in other kinds of specialties, it's okay to make people travel to get their fancy workup at the regional center, once a year or less, or several times a year. So I think we need to think about different healthcare delivery models and the way we can use technology to expand that expertise to other places, because you can also do a lot with local teams who maybe are doing the physical exam and you're doing the consultation in collaboration with their local team and not trying to take it over from their local team. And that expands the expertise as well. After you do a number of those consults, the local team is a lot more expert than when they started.
So you were you at UCSF in 2000 when we had this failed experiment of UCSF Stanford healthcare?
I was.
So was I. That lasted less than a year. I'm thinking
I only saw the remnants of it by the time I got there. There were still some papers that had both on there, and I was like, why does this say Stanford? And then someone's like, oh, don't even get me started.
So we have a unique opportunity at Stanford. At least I have an idea that isn't so original, but I want to create a disability center of excellence.
Mhm.
I could call it DISCO, but somebody already took that acronym at Stanford for community center, which is very upsetting. But I'll still refer to it as the Disability Center of Excellence. Part of that would be research, education, advocacy, but also health equity for patients with disabilities. I think that's really important for any disability center. So how can we partner with you, Dr. Kripke, up the road without merging to like band together and raise funding and create a center to care for patients with disabilities in the Bay Area?
Let's do it. I don't think there are barriers except competition, and I don't think we're in competition. So let's do it. That's a wonderful idea. There is a disability clinic in East Bay that provides some good care for people with physical disabilities and does some of that work that Amy was talking about. So there are some models for this. So part of the problem is that mental health is people with complex mental health issues have a system that's organized by county, regional centers, organized by several counties together. Health plans have completely different geographic areas that they cover and may not cover all the people who have similar needs within a geographic area. And so yet these services are needed everywhere. And so we're going to have to break down some of those silos and barriers. And that's one of the things I love about family medicine, is that we're not afraid of complexity. We're not afraid, we don't recognize silos. And I think disability work and disability justice is going to require us to work across systems. It's going to across political systems and across disciplines. So let's use our disability justice principles to break it down and just do it.
Awesome. I'm so excited about this. I mean, we've been talking about where to potentially house this because, like you said, disability lives everywhere. But it seems like logical places could be family medicine, physical medicine, rehabilitation. We're thinking about our complex care clinic, which I've heard is like very underfunded and has wait times of up to a year for a new patient visit, which is just heartbreaking to hear. Can you talk a little bit more about this political backsliding we're undergoing at the moment and what we can do to protest?
One thing I was thinking about during Alice's and your discussion was about how we as a society have decided to run long-term services and supports through Medicaid, which is both a healthcare and a poverty program, and yet people with disabilities, we basically require people with disabilities to be poor in order to access the services and supports they need. And we run any financial support for people with disabilities through SSI, through a program whose definition is that you can't work. And we obviously know that people with disabilities can work and can make contributions. And so there are some fundamental structural problems with how we have decided to organize therapy services, which we've inherited from people who had different attitudes about disability that Dr. Hinshaw talked about so eloquently. And some of the problem. So I think we need to think about what the role of government is. Yeah, mutual aid is really important, and government's not going to save us, but nor do I think people with complex disabilities think mutual aid is going to be enough, or that we can do without government supports and without these programs. And I'm the daughter of two physicians. I'm a physician. I never in my wildest dreams before I had a child with a disability thought that my ability to work, my child's ability to maximize their potential would be dependent on us qualifying for a poverty program. And yet that's where we find ourselves. And I think that it has given me new respect for those programs. So I think those government programs are really important, and we need them, and we could not have done it without them. And now we're going through transition and we need them. And I have wealthy Silicon Valley people coming to me saying, we have a lot of money. We don't need regional center. We have that kind of money. And I say to them, yes, you do. You still need to apply for SSI. You still need to apply for Medicaid, and you still for Medi-Cal. You do need these systems because there isn't an alternative system for you to pay for, and they become isolated, and we do need each other, and we are interdependent, and you can't buy your way out of that system. Nor do I think that would be better if we could. I think we're a community and we need each other, and this illustrates that.
And I would just want to put one plug in, is that the home care workforce is definitely underpaid. So we're talking about making less than $12 an hour for work that can be quite laborious. It's incredibly rewarding work, but it can be laborious. And I think raising the standard of wages for the home care workforce would help grow the home care workforce. There are other aspects of the home care workforce that we could talk about. I know we're at time, but I think that's another area that people could advocate for, which is making sure that we have more stability of that workforce by paying them what they deserve to be paid.
But yeah,
Caregivers in our area make $30 an hour plus. But there's such a, because the area is so expensive to live in, there's a scarcity of caregivers. They often travel in from far, and they're not going to do it for $12 an hour, thankfully, nor should they. But I have a question here from the audience. Might rehab medicine be rebranded as disability medicine? Would that better support those with lifelong disability journeys?
What an interesting question. I would say that there's a number of practitioners in PM&R rehab medicine that don't really consider themselves focused on the care of people with disabilities. So they might be taking care of athletes, for example, who have temporary injuries and are going to go back to the field, and it's their rehabilitation that they focused on. Or they might be focused on lifestyle medicine and nutrition and other kind of functioning optimization, but less about the care of people with disabilities as the core of what they do. Certainly in the area of rehabilitation medicine, where people are getting services after a traumatic brain injury or a spinal cord injury, that is obviously disability medicine. But man, it would be nice if it was easy to understand what the discipline did and who it was meant to serve. And I appreciate that comment, because I think one thing that's really interesting in pediatrics, we have an entire discipline, developmental and behavioral pediatrics. It's a subspecialty out of pediatrics. It's fellowship, but there's no such thing out of internal medicine. So there's no field of developmental disability medicine for adults. And I'm so grateful for people like Clarissa who are in family medicine, who don't have to deal with the transitions we deal with, but who are picking up that slack, because we need it. And I think there's a lot of opportunities to enhance how we train individuals. And maybe there's a special fellowship yet to come for adults, but we got to do it now too, right? We can't wait for that to happen.
Yeah, hold that thought for the wrap-up session at the end. We did have like a lot of comments and questions about the training of practitioners to take care of patients with disabilities. And actually, I believe that Andres Gallegos is going to talk a little bit about that also. So we are heading into our lunchtime. We're going to be taking a 45-minute break for lunch. If you would like, you can join us on social Zoom. The link is in Slido. And we're going to come back here at 12:15 p.m. for session 4, which will be Andres Gallegos, the chairman of the National Council for Disability, who's going to be talking about a voice for health equity. So I'm going to go hang out in the social Zoom now.
Well, thank you, everyone. It was a delight to be here, and I'll see you later on.
thank you. Looking forward to talking to you more in the breakouts.